Okay, so I can see my face on Facebook now, I guess, on AMN Healthcare International Facebook page, including IPAS processing page. Okay, so let me see your chats on your comments. Okay, and see where you're coming from. I can see your comments here, by the way. Okay, so let me see. Modis, good morning. Good morning. It's been a while. I haven't been here. I guess it's been 2 months. Yeah, it's been 2 months. So time is really running so fast. And then here we go again, like doing this stuff for you guys. Okay. Good morning, Miss Modis. We have some 47 live viewers, and it's gonna go up for sure. Just a little shout out coming from you guys. Okay, I can see the emojis coming in, popping in. Shout out from Saudi Arabia, Miss Modis or Mr. or Miss Modis is coming from Saudi Arabia. Miguel is, I'm not sure where you come from. I guess you're from the Philippines. Of course, Fern is also watching. He's from IPAS Processing. Kirito is from Kenya. Yes, sir. Fern is coming from Japan as well. So this is a particular shout out, of course, for the international nurses that are aiming to come here in the US. Okay, so Labrina is also from where? From Dipolog City in the Philippines, somewhere in the south. Right? So from UAE is Mr. Mark, Miss Welin from Abu Dhabi, Mr. Kyle, Mr. Jaron is also here in the US, also our students before in IPAS, right? So he's already in Florida right now, and then he actually came from Canada. Our loyal friends, and they're actually our family already. Okay, so Miss Chavez is from Pampanga, or Mr. Miguel, sorry. Of course, Rose is, of course, from KSA, our one of our mentors. Jen Lo is from Baguio. All right, Kitty is also from US here in Kansas. She's also our students. Okay, so I guess we are going to start now, right? So this is a merge, or a project of AMN International, and as well as IPAS Online Review and Mentoring Academy. Hi everyone, hope you're all doing well this season of joy. I'm happy to be here again, of course, together with AMN International, utilizing this beautiful, platform uh, to bring the best information possible, of course, to hurdle your NGN NCLEX. All right. So I know it's gonna be difficult. I would not say it's difficult. It's challenging, but I know with your trust to yourself and trust to God, more importantly, I know you are going to make it. Okay. So my name is Jay. I am the co-founder and lead educator of IPAS Online Review and Mentoring Academy. We are here today for an hour lecture about certain topic. I'm not gonna give you the topic yet. All right. So if you can see, it's only saying like a drill, something like that, right? It's a common topic for sure in your NGN and NCLEX. Particularly, we will answer a test drill in a form of a bow tie question. Okay, so you've heard about that already. So it's one type of NGN question coming from a case study. It will be for sure a very common topic in the exam and also in the clinical setting here in the US. That's more important, right? It's not only passing your exam. I'm not going to tell you the specific topic, like I said, until we were able to decipher, the core of the case study. Okay, that's what is NGN is all about. Okay, so it's basically a case scenario. By the way, I'm situated here in Beaumont, Texas, somewhere southeast. I wish y'all be here soon. But one thing for sure, you have to pass or make it to your NCLEX. Okay, that's your ticket, in coming here to the US. All right. So, by the way, you can also make use of it in Australia and as well as in Canada. So, without further ado, let's dig in. All right. So, please don't forget to share it in your social media. May it be Facebook, Instagram, if you have TikTok, if you have YouTube, whatever social media platform, I'll be glad to to see it, guys. We are actually live in or through AMN and IPAS Facebook channels. Okay, so kindly share it to your Facebook or any social media platform. Okay, so I guess I'm going to share my screen now. Hold on. So we can start. Hold on. I don't know if you can see my screen. Hold on. Just give me a yes and then I'll proceed, okay? Let me do it again. I think I cannot
Cuman nih,
hold on. How about that, guys? Can you see it? Not yet. How about that? Is that okay? Miss Esther said it's no. I guess it's showing up now. I'm sorry. Oh, there's someone is shouting out from Shararout. Mr. Francisco from or Miss Sunny from Taiwan. Miss Jen is from Baguio for sure. Yeah, I already mentioned it earlier. Yes, there you go. So we can start now. Okay. So I'm gonna give you a background first with your next generation NCLEX. So what is it all about, especially for those who are newcomers? Okay. So let me see. Let me just yeah. There you go. Okay. So there's a lot of mixed emojis here. I don't know. There's a lot of mixed emojis. So let's be positive, guys. All right. So I like that. Shout out from Ghana, Miss Nana. Esther is also from Zambia. There you go. So we are really a group of international nurses here. Sylvester, for sure, from Bulacan, Philippines, is also one of our coaches. A very enthusiastic coach in our, in our academy. Senor from Dubai. All right. So I guess you can see my screen now, right? All right. So if you see, everyone is ready, right? Okay. So if you see, this is the six functions of clinical judgment. Your NCSBN is really like into it, like into clinical judgment stuff, right? Well, technically speaking, practically speaking, whatever the NCSBN, the tests plan, the NCLEX per se is really up to clinical judgment. They are really testing you a lot better on how you use your clinical judgment. All right. But first things first, you are not going to make use of your clinical judgment if you don't have your critical thinking skills. So it's like a skill, right? So critical thinking, it's how you think, all right, before you arrive in a sound, safest, and the most standardized and the most effective nursing care to your patient. That's basically clinical judgment. So critical thinking first, it's a skill. They're gonna test you for sure before you arrive in a sound, safest, the most standardized, the most effective nursing care or nursing, delivery of your care to your patients. Okay, once you come here to the US, your patient is safe. At the same time, you are also safe. Your license is also safe. But of course, you're gonna hurdle this NGN NCLEX first. Okay, so they base it from the six functions of clinical judgment. So this is basically your nursing process. If you look at the bottom, it says assessment, analysis, planning, implementation, and evaluation. They broke it down. They broke it down into a more specific, skill. That's basically critical thinking skills in terms of recognizing cues on how you assess your patient, on how you analyze what are your cues, on how you prioritize, oh, what is this all about? What is this problem that my patient is, experiencing? All right. On how you, okay, these are my hypotheses. I think the patient is having some form of pulmonary embolism, for instance. All right. So what I'm going to do then, generating solutions. These are basically your nursing interventions that you need to do. Of course, it's either independent or interdependent with other, collaborative with other health, team, right? And then taking actions, so how you're going to implement it, okay? And lastly, of course, we need to evaluate our plan. We need to evaluate our outcome. If you meet the outcome or if you did not meet the outcome, in that case, you have to modify your nursing care. Okay, so again, they broke it down into a simpler form to assess your skills specifically from 1 down to 6. Okay, so again, this is a better way of assessing your clinical judgment. Okay, remember, this is a test, right? So this is your, I just found it out. This Tanner's clinical judgment model, it's one way of, um, you know, uh, explaining what we do in terms of how we exercise our clinical judgment. It's Tanner's clinical judgment model. If you look at in the middle, this is your NCSBN, right? This is your NCSBN. Look at it. You first recognize cues, you analyze cues, you prioritize cues, you generate solutions, you take actions, and you evaluate outcomes. Translate it to your nursing process, the conventional nursing process. First is assessment. So that's basically recognizing cues. Second is analysis. That's basically analyzing cues and prioritizing hypothesis. Are you getting me, guys? So analysis, again, analyzing cues and prioritizing hypothesis. Okay? And planning, it's basically generating solutions. Implementation is taking actions, and evaluation is, simple evaluation of outcomes. Now, according to Tanner's clinical judgment, yeah, of course, she's also a nurse. She actually, just a little, background about Tanner. Christine Tanner, she developed this model about clinical judgment and collaborated with Patricia Benner, if you know Patricia Benner. So this is her model is a framework that describes how nurses think and make decisions in a complex care situations. In the first place, why are we putting you or why are they making an exam which is uh, opted to really exercise or make use of your clinical judgment or test your clinical judgment, right? In the first place, because we are dealing with a lot of complex situations here, all right, with a lot of complex situations here. And at the same time, we are also avoiding errors because majority, 65% of the errors that we commit in general are actually related to clinical judgment. That's according to that's according to nursing, American Journal of Nursing. Okay, so we are dealing with complex situations. I'm talking about complex conditions. Before, in the 1990s or in the year 2000, we only take care of a patient having CHF and then let's say AFib. That's it. Or let's say hypertension and diabetes. Or sometimes it's only diabetes, right? But nowadays, everything is there. Name it, and you all have it. All right? Diabetes, AFib, like CHF, COPD, asthma, and everything. It's always there. That's why it's very complex, and we have to keep up with the complexity of this, nursing care. And we're not only dealing with nursing care as well. Of course, we need to keep up also with the medical treatment that they are into, right? That's how we are nurses in terms of communicating with the health team, the whole health team, right? Particularly the of course the medical doctors, right? So in Tanner's clinical judgment, uh, so she was able to like simplify. So assessment is basically noticing on how you notice, stuff, or how you notice what's the problem with your patient. Interpretation or interpreting, you interpret what did you notice. Responding and reflecting. Reflecting means what? I'm gonna reflect what I'm gonna do then. Okay. Do I need to change this intervention or not? Of course, you need to collaborate with your, with your team, right? So again, here in the US, the practice needs to have a team effort. All right, you cannot just do it alone. It has to be coming from from you guys, the nurses, and as well as the doctors, and more importantly, the participation of your patient. That's why education is very important. That's our approach here. Does that make sense? Okay. So let me move on. Let's go to your case studies. You know for the fact that your case study is it's either unfolding. Unfolding case studies comes in 6 particular questions, sequential questions, assessing your clinical judgment based on that, model from NCSBN. All right? Remember, from recognizing cues to evaluation of outcomes. So they're going to assess you from there, from 1 to 6. That's unfolding case study. Again, it's based on a case scenario. Secondly is the standalone case study. Sometimes they call it trend. The standalone case study is a case study based on case study and only one question. All right, and only one question. So standalone case study, again based on case scenario, and only one question. And lastly, we have your bow tie because it will really look like a bow tie. All right. So for today, we are going to discuss to you, or we're going to answer a drill, which is a bow tie format of a question, bow tie type of question. All right. So unfolding, standalone, and bow tie. Most of the time, you will get unfolding case study. All right. A minimum of 3 unfolding case study. It can go up until 5 unfolding case studies, but they're only going to grade you only for 3 case studies. But you will not know, for example, like if you're getting 5, but you will not know what are the 3 case studies among the 5 that are graded. Okay, so that's how tricky, your NCSBN. But they are not there to, don't be scared. They're not there to fail you guys. Okay, it's just as it's a challenge, just like any other test. But again, as long as you plan well, I think you're gonna make it. All right. All right, so this is your problem. This is what it looks like when you have a bow tie question. On your left side, you will see the case scenario, and if you look at the buttons, like in your nurse's notes, you just have to click it, and then you will see the information. If you click the history and physical profile, you see the assessment, and you see the background of your patient. The medical background, the medical history of your patient, vital signs, of course, and you click the physician's order, and you see the orders. All right. So, and on the right side, you will see the question. Okay, you will see the question. So, for instance, this is what we're going to answer. Okay, thank you, AMN, again for this opportunity for us to bring a relevant topic or sharing of information like this. So let's start. Okay, so let me just minimize this one. Hold on. Oop. I have 2 screens, by the way. So, but anyway, so let's start. Let's read it. The nurse cares for a 66-year-old male admitted to the emergency department. A 66-year-old male client admitted to the emergency department. Okay. So nurse's notes, when you click the nurse's note button, right, it will show 1600. We use military hours here. That's our official, format. Okay. FM, Mr. FM. Again, he is a 66-year-old. Came to the emergency department. The client has a history of diabetes. Okay, history of diabetes, treated with metformin and glipizide. These are our oral hypoglycemics. The patient had a CID, or coronary artery disease. She had some 2 stents before put in. And the patient is also taking clopidogrel. Clopidogrel is an antiplatelet medication, right? It's a blood thinner. All right, it's a blood thinner. It's a different category. It's an antiplatelet specifically, just like your aspirin, but they have, a different mode of action. All right, this is not an anticoag. All right, this is not an anticoagulant. Those are 2 different things. Right, anticoags and antiplatelets are 2 different things. Thrombolytics are another, a different category. All right. So antiplatelets, just like your aspirin and your clopidogrel, but again, like I said, they have 2 different mode of actions. All right. So Hypertension treated with amlodipine. So comorbidities again. Comorbidities, let me give you a highlight with your diabetes. There you go. With your CAD, coronary artery disease. A coronary artery disease is basically a general statement, a general diagnosis. For example, it's like a spectrum, all right? A coronary artery disease can be in a form, for example, of stable angina and your dreaded myocardial infarction. You have to know this, concepts. A myocardial infarction, for instance, by the way, there are two. We have your non-STEMI or non-ST elevation MI, and the other one is your, of course, the most severe, the ST elevation MI, wherein there is, a big damage to your heart. Okay, your transmural damage, if you wanted to be like, more specific. But anyway, these are just some of your medical history, and the patient is also having hypertension treated with amlodipine, a calcium channel blocker, the most, potent among all the blood pressure medication. Right? It's always like the calcium channel blocker. The least potent would be metoprolol. Your beta blockers. Beta blockers are primarily for your arrhythmia, not necessarily secondarily. It's for your blood pressure. All right. So this knowledge, you need that, especially in answering your NGN. All right. He was complaining of right knee pain and swelling. Let me give a highlight on that. Hold on. And swelling. Okay. Oh, sorry. Where was that? Let me give a highlighter. There you go. So the patient had a right knee pain. That's the immediate, complaint of your patient. Why did this patient came to the hospital? All right. Patient stated that in 24 hours ago, he had a bicycle accident and scrapped his right knee. There you go. Scrapped his right knee. It means to say like, there's an open wound. Okay. There's like an abrasion, but again, definitely there's an open wound. Okay. So the right knee noted to have swelling in pain, persistent non-profuse bleeding. The good thing about it is that it's non-perfusing. Okay, in the site is evident. This is the nurse's notes. In the morning, the patient woke with a fever of 103. Let's give it a highlight. 103, right? And feeling dizzy. So these are really abnormalities. These are unusualities. Basically, these are not normal for this patient. That's why the patient came to the hospital, right? So Mr. FM was treated with at home with moist saline dressing every 4 hours, and his family thought it was improving. In the afternoon, I guess the patient is not really deteriorating though, but well, it's not improving. All right, it persisted, and his daughter noticed that Mr. FM is confused. All right, so there should be a reason why this patient is confused, right? So there's a mental status changes, right? So the daughter brought a patient to the ED for acute treatment. Okay. So point of care, when you say like point of care, you don't need to have a laboratory technician to get the blood. Like, you just get it and then there you go. You already had your blood sugar. Remember, this patient is diabetic, right? The patient is diabetic, so the nurse took the blood sugar test, and then the result is 80 milligrams per deciliter. Of course, you need to know the normal, right? So 80 is within the normal range, so there's nothing really a problem with your diabetes here as we go along in our problem, right? So don't look at the right side of your screen yet. Okay, look at the important parameters first. Remember, it's going to assess you with your clinical judgment. First is your recognizing cues. First is your assessment. That's very vital here in the US. If you are not used to use your stethoscope in the Philippines, that's a very classic example of mine. If you're not used to use your stethoscope in the Philippines, if you're not bringing it in the hospital, well, if you come here to the US, you make use of your stethoscope because you really have to use it to hear, what's going on to your patient's lungs. All right. So yeah, so that means to say that we are very particular in your assessment. All right, so the vital signs are 101. There you go, it's 101. What is this? 38.3 in degrees Celsius. That's the good thing about NGN. They're going to also put the equivalent, and they're also going to put the reference values for your For example, like your electrolytes, all right? So the normal values. But in your vital signs, they don't need to put it. You know that very well because that's what you're doing, routinely in the hospital, right? That's very basic. Pulse rate is 90. So 101 is basically a patient is having fever. The pulse rate is a little bit high. Well, the normal is 60 to 100. It's still within the normal range though. But yeah, so with fever, it can go up at any time. That's why you need to monitor your patient. The respiratory rate is the normal range is 12 to 16. All right, 12 to 16. 20 is high. The patient is tachypnic, right? 115 over 65. This is normal, but again, we are monitoring your patient, right? And the pulse oximetry is 93%. The patient is on room air. You don't need to have an auto supplement, to bring it up. It's normal, 93%. 90 or 92 higher is basically, your patient is saturating well with that oxygen. Okay. So that's your baseline vital signs. We can probably look at as we go along with the other problems, okay, if the vital signs is improving or not. Okay, so let me move on to, don't take a look at yet, the right side of your screen. Okay, so you're thinking about, okay, by this time you already have your parameters, you already have your cues. All right, so this time you probably thinking of something in your mind like, oh, what's this, what's the problem of my patient, what do I need to do? All right. So can I see what's going on here? Okay, I'm just gonna ask your opinion here. I mean, this is clinical opinion, huh? This is based on knowledge. That is critical thinking is all about, guys. That is basically NGN. It's basically exercising what you think, how you connect the dots. That's basically critical thinking before you arrive in a sound clinical judgment, right? So what's the problem here, guys? Come on. What's the problem here? So what do you think is the problem here? Based on the immediate complaint of your patient, based on the vital signs, based on the cues. Come on, I want to see your comments. I'm looking at the Facebook comments. Come on, guys. Come on, come on. Come on, international nurses. Come on. Let me see your comments. Come on, I can't see it. Okay, sepsis, infection. There you go. It's a very general statement, which is acceptable for sure. But we can dissect that later on. All right. So sepsis, infection. Mr. Kyle said infection. I think in general that's what you are thinking, which is really good. But again, in terms of, you cannot just stop from there. You have to have a background knowledge about infection. All right. In such a way that you know what is sepsis, what is septic shock, what is organ system your multi-organ dysfunction syndrome, and what is your SEERS. That's your background knowledge. I'm probably gonna discuss to you about that later on. There's fever, so basically there's an infection, there's an inflammation, right? So not all infection, I mean not all fever is blamed, because of infection. There's an injury. There is, if you have an infection, definitely there's an injury. All right. So that's why you have a fever. That's how you look at that way. But anyway, fever is really a significant parameter if you have infection. All right. So, what is this? The Jron, what is this? MEWS is going down. Mental status, is that what you're saying? Okay. So let's proceed to the other parameters, guys. If you proceed, okay. So let's see. The next slide would be still the nurse's notes. Okay, still the nurse's notes. On 1800, after 2 hours, the patient is increasingly confused. That's increasingly, sorry for the technical error, and agitated. Mental status changes. So this is a deterioration, all right? Having difficulty of breathing. There you go. This is a very important parameter here. Fluids initiated, all right? Given 500 ml bolus as ordered by the physician and has been tolerated by the patient. Okay, tolerated well. In other words, the difficulty of breathing is did not improve or did not progress, I mean. All right, so the vital signs, it's still the same. 101, when you check it after 2 hours, but the pulse rate is going up. There's something wrong here, guys. And the respiration is 27. It's going up, going up, going up. Respiration, like, difficulty of breathing, tachypnic, patient is tachypnic. The blood pressure is going down. All right? The blood pressure is going down. So if you already prepared for that long in your NCLEX and then you're about to take in 1 month, you should know the concept, or the sepsis continuum. If you're practicing in the hospital, you all have your policies to your sepsis continuum. Your SEERS, your sepsis, your septic shock, and your multi-organ dysfunction syndrome, in which you don't want it. Definitely, if your patient is having septic shock, it has to go to ICU. Needs some, immediate intervention. Okay, so 90/55. This is going down. There you go. Pulmonary embolism. Not much in terms of looking at the cues, right? Septic shock. There you go, because the blood pressure is going down. But let's take a look at it. Miss Kitty, very good, very good. Shock because of the blood pressure. Very, very. If you just look at the parameters, and then you'll be able to get it right. And then the pulse oximetry is going down as well. And then the fact that the patient is already having 2 liters per minute, nasal cannula supplementation, and it's 90%. It's going down. There you go. So there must be really a problem here. Okay, it started from a wound, and then the patient is not doing well, and they went to the hospital, and then there you go, infection, right? So infection, septic shock, hypo, taki. There you go. These are your knowledge, the background knowledge that you are preparing well, for the past few months, if you're preparing, before you take your examination. So really, this is about knowledge. And when you talk about knowledge in your NCLEX, this has to be like, this knowledge are very specific, and at the same time relevant to what you are going to answer in your NCLEX, all right? Especially for the common topics like this. So just to give you a little background, 40 to 60% of your patients critically admitted to the critical care are coming from sepsis. That's how that's how common this sepsis is. All right, so you really have to look at it, because again, NCSBN will definitely give you common topics that we see here in the hospitals. And I'm not only saying about the US. I'm also talking about the worldwide trend about sepsis. They're just basically evolving. All right. Nowadays, for me, there's no such thing as community acquired infections. There's no such thing as hospital acquired infections. I mean, there's no such thing as hospital acquired infections. Everything is actually acquired from the community. All right. So what do I mean by that? MRSA. MRSA can only be acquired in the hospital after 3 days of stay in the hospital, right? After 72 hours. But nowadays, if you work in ER, even at the admission, the patient is already having MRSA. So what do you mean by that? It's not hospital acquired. And again, the fact that MRSA before it's only acquired in the hospital, these are potent, these are very virulent microorganisms, right? And nowadays, you can see that in the in the ER. That means to say it's community acquired already. Does that make sense, guys? It's for me, it's only in the books, but well, we still have to apply, what's as much as we can, right? But in a practical setting, there you go. You can see those MRSA uh, develop, in a span of how come this is developed in the first place? The patient is just admitted, within 24 hours. Well, it's already community acquired. And it's not talking about only MRSA, Pseudomonas, ESBL forms like, Klebsiella and all those stuff, right? But anyway, let's move on, guys. So we can answer the problem. So vital signs is, temperature. There you go. It's the same thing, all right? Just to give you, to emphasize that. The medical history, it's been given already based on the nurse's note, CAD and hypertension and type 2 diabetes. Patient is taken metformin and glipizide, all right? And then let me move on to the other laboratory is, there you go. WBC is elevated, 12,000. The hemoglobin is 12. For now, I don't really care about the hemoglobin, all right? And the hematocrit is 38%. The platelet is 350,000. Why do you think the platelet is elevated? This is just a form of reaction. It is only reactive. All right, so that's why it's elevated, because in any form of injury, platelet will also increase. they try to like, okay, I'm going to like, do my job, like, all right, so it's reactive. So, but it's not really the problem here. It's the WBC. All right. So that's a sign of infection. All right. So let's take a look. Okay. So the physician's order, monitor vital signs closely. NS bolus 500 ml, which is already carried out, and regulate to 100 cc per hour. Acetaminophen, we don't use paracetamol here. We use acetaminophen. All right. It's very laid back, right? Every 6 hours for fever. Okay. Obtain pan cultures, your blood cultures, urine cultures, sputum cultures, whatever cultures. All right. Or wound culture. And then start vancomycin. We usually start with an empiric, kind of antibiotics. Vancomycin is leaning towards gram positive, right? Most likely, this is a form of staphylococcus. We just don't want to. We just don't know if it's if it's resistant. I mean, if it's MRSA or methicillin. What do you call this? If it's methicillin resistant or sensitive. All right. So vancomycin, most likely this is a staph kind of infection. That's why they started right away with vancomycin. And again, like I told you, MRSA is everywhere. That's why they start it with a strong antibiotics because suspectedly this is a form of MRSA. Okay? And the patient is developing shock already. As soon as possible, you're gonna start a very strong antibiotics. Like I said, vancomycin is leaning towards a gram-positive microorganism, all right, which is your Staph aureus. Staph aureus is a gram-positive one, all right. And MRSA, the drug of choice for the antibiotic of choice for your vancomycin is your is your vancomycin. I mean, the drug of choice or antibiotic of choice for your MRSA is vancomycin. Okay, so lab works per protocol, like your CBC and your CMP, like your comprehensive metabolic panel, electrolytes, the liver panel, and the liver panel and your renal panel, and then refer to orthopedic specialist. To orthopedic specialist because remember the wound is at the that extremity, that knee, right? So let's answer, guys. Okay, let's answer. Okay, let me answer or let us answer this question. So the nurse is reviewing the client's assessment data to prepare for client's plan of care. Okay, so complete the diagram by dragging. So you can make use of your mouse. You know how to drag an item, right? So by the way, for the first I guess it's like 10 minutes. For the first 10 minutes of your exam, they're gonna tell you about how to use or how to, instructions, how to use the computer. All right, and it's very simple on how to drag items from one to the other. For example, you're gonna drag. Hold on, let me just switch it to my pen instead of the highlighter. So, for example, you're going to drag this one. If you know that's the answer, then you drag it here, right? You drag it there. So the two boxes. Like I said, this is a bow tie question. It looks like really a bow tie, right? The one in the middle, which is the potential problem, and the action to take, two actions to take, and then parameters to monitor, two parameters to monitor. The most important parameters. Okay, so complete the diagram. I'm just going to read it by dragging from the choices below to specify what condition the client is most likely experiencing. Okay, two actions and two important parameters. It could be all important, but what we're looking here are the most important parameters and the most important actions to take related to that problem. So for me, I'm going to, of course, I'm going to pick first the potential problem. I'm going to drag first. What's the diagnosis of your patient? Again, this is your diagnosis here. These are your diagnosis. You think that it's like a ruling out kind of, strategy, right? You're trying to rule out if this is hypoglycemia, if this sepsis, septic shock, osteomyelitis, or ARDS. Okay, let's take a look at your hypoglycemia. Let's eliminate what is needed to be eliminated, right? So hypoglycemia. You think there is hypoglycemia here? Well, the patient is diabetic though. Anytime the patient can be hypoglycemic, all right? But if you look at the blood sugar and the point of care testing, it was normal. So I guess I'm going to eliminate this. All right, so I'm going to eliminate that. I'm not going to drag it. Simple, right? It's very simple, basing on your cues, right? So what about sepsis? There's sepsis and there's septic shock. Remember, the sepsis continuum is composed of what? Sepsis, I mean, SEERS, all right? SEERS, sepsis, septic shock, and your multi-organ dysfunction syndrome. Okay? So, sepsis or septic shock, it's between the two, right? Is this osteomyelitis? It can happen, like osteomyelitis, infection of that bone, particularly to that knee. All right. So, but we don't know until we like do the biopsy or do some samples from that knee. So I'm going to eliminate that. All right. I'm going to eliminate. It's either sepsis or septic shock. We're just gonna take a look at it. I'm going to discuss to you the background knowledge about this to really distinguish what is sepsis from what is septic shock. All right. And then ARDS. It could happen. ARDS could happen. Remember, the patient is already developing shortness of breathing. All right. Remember, your ARDS can also develop in the presence of your sepsis. Right. In the presence of your sepsis, your respiratory failure can happen. And that's your ARDS. All right. So acute respiratory distress syndrome. But in terms of the parameters, if you take a look at it, like your vital signs, it's greatly increasing. The patient is tachypneic. But for me, I guess you would agree on that matter. I guess this patient is just basically, compensating. All right. If ever you have a problem to your, for example, like sepsis, for sure you're going to compensate. Is it, compromising your respiratory status as well, your oxygen, delivery and everything? Yes, definitely. Remember, your patient is at stress. But remember, this is only a compensatory mechanism. It's not necessarily a decompensation mechanism, right? We're in. When you say like decompensation, it's already leading to ARDS because you are already losing you're already maxed out, in other words. Okay, you're losing already your physiologic balance if you're talking about decompensating. Those are two different things, compensating and decompensating. Compensating, you still have your balance, all right? Decompensated, for example, the word like, decompensated congestive heart failure. Decompensated, which means like, you're already losing your physiologic balance. You are not able to keep up with the condition, with the disease condition, okay? So here, it's not ARDS. All right. Even if your patient is tachypneic, you cannot just simply, oh, okay, that's ARDS. No, I'm going to eliminate that. So it's either sepsis and septic shock. Now, how are we going to distinguish between the two? Okay, let me give you our, hold on. Let's just keep it. Let's keep it for now. Hold on. So let's see my blackboard. So this is my famous blackboard in IPAS. All right. So let's take a look at your sepsis continuum. Let's discuss a little bit about this sepsis continuum. Okay, when you say like continuum, all right, from here to there, all right, so from mild to severe, okay, and it can happen in an instant, from being mild to being severe. Okay, so your patient, if you have mild, sepsis, your patient can stay in, can you see my screen, guys? Your patient can stay in the regular floor or in the regular unit, right? But for severe, for example, of course, this patient has to be taken care of, monitored closely. The patient can go to ICU, right? The patient can go to ICU. Patient needs fluids and everything, right? The pressors. So number one, we have your what? We have your SEERS, right? We have your SEERS. SEERS means what? Systemic inflammatory response syndrome, right? SEERS means systemic inflammatory response syndrome from the word itself, systemic. Your body is just simply compensating. Your body, your system is simply like responding to it. Systemic inflammatory response syndrome. It's a group of symptoms wherein basically your patient is responding to an inflammatory response coming from an infection. So there are four criteria, right? There are four criteria. In terms of WBC, in terms of temperature, in terms of respiratory rate, and what's the other one? In terms of your heart rate. Those are the four important parameters. It could be a different one in your, but these are the four standards that we have that's applicable to any hospital. But it depends upon your policy and what's your range and what are the other parameters that you need to consider. But at least 2 out of 4 among that criteria, right? So the WBC, the normal is 5 to 10,000. You know that very well. So it's either if it's 4,000 or less, okay. All right. So this is leukopenia, right? So decreased WBC. Okay. If it's less than 4,000, you could say that it's a criterion of your SEERS, right? If it's more than 12,000, well, you could also say that it's leukocytosis, right? So it's either leukopenia or leukocytosis. Either way, okay? In terms of your temperature, so you know how you have to know what's the normal value of your WBCs. Well, it's very basic, guys. Are you still with me, guys? Are we still good? Hope you're learning, huh? Hope you're learning, especially in answering these kinds of questions. Of course, we have to back up, with your knowledge about sepsis continuum, right? And then temperature. Temperature is for example, yeah, the normal is, I mean, let's just look at the parameter, the abnormal parameter. If it's less than 36 degrees Celsius, okay, so hypothermic, okay, hypothermic, yeah, it's okay, right? It's a parameter. Or or if it's more than 38 degrees Celsius, it's a high fever, right? It's not that high, but it's still a high fever. It's not a low grade fever, definitely. Okay. So 36 in degree Fahrenheit is 96.8. Yeah, that's correct in Fahrenheit. 38 is 100.4. That's what we use here, right? In the US, degree Fahrenheit. But you see that in your NCLEX with the conversion. Okay, you don't need to convert. You don't need to use your calculator and then you convert what's the formula and everything, and all those stuff. No, it's not. You don't need to do that. Respiratory rate, if your patient is having some SIRS, systemic inflammatory response syndrome, your respiration will get high for sure. All right? So 20 or more cycles per minute. That's your respiration. Okay? So the patient is tachypnic. Or if you take a look at your ABG, if you have your ABG, baseline, but we don't much do the ABG, not unless if the patient is really in respiratory distress, right? So because it's very painful, you have to think about that as well. You cannot that indicate that simply to your patient or easily to your patient. PCO2 is less than 32. Okay, the normal is 35 to 45, right? For sure, the patient is tachypnic. You're losing a lot of CO2, so that's why your CO2 will be lesser. If it's less than 32, it's a parameter. Okay. First, we're not gonna talk about the ABG here. It's a different topic. So your heart rate is more than 90. Okay, more than 90. So the patients, in the case, so more than 90 beats per minute. In our case scenario, it's already 115. So that means that the patient is already developing SEERS. WBC, let's take a look. WBC is already elevated, 12,000. So that means to say the patient is in there, in this continuum. Temperature is already, yeah, it's already 101. So temperature, the respiration is already elevated. It's 27 already. And the heart rate is already 115. So everything is there. These are the criteria for your SEERS. Okay. That will develop into a more severe one, which is sepsis, right? So this one is your sepsis already. Can you follow, guys? Yeah. Sepsis. In your sepsis, we have SEERS, definitely, plus the suspected infection, or for instance, the identified infection already. Okay, the patient has UTI. All right. Patient has UTI. So identified. I'm just going to write here identified infection. Okay. The infection is coming from UTI. The infection is coming from the wound. The infection is coming from pneumonia. The infection is coming from an infected device, for example, like, the tunnel cut is kind of infected. So there you go. So identified infection. Identified infection. Okay? Or suspected infection plus the SEERS. All right. So sepsis, the next one would be what? I'm going to put an arrow, is your septic shock. Okay? The next one to your continuum is your septic shock. This is going to be difficult. All right? This is going to be a challenge. This is going to be a challenge, guys. Septic shock is SEERS plus your sepsis plus your what? Blood pressure. The blood pressure is also already going down. Okay, especially using your MAP, your mean arterial pressure, which is less than 65. Okay, which is less than 65 mmHg. You know how to measure the MAP, right? 2 diastolic blood pressure plus systolic blood pressure, that's another knowledge, divided by 3. Okay, if it's less than 65, I'm gonna write it well, sorry. If it's less than 65, there you go. You have the SIRS, you have the sepsis, suspected infection, identified infection, plus the blood pressure is already going down. The MAP is less than 65. If you measure it, most likely that patient is, based on our scenario, most likely that patient is already developing septic shock. Okay, I think I got the answer already, sir. Okay, so the patient has everything in there, right? So the SIRS, sepsis, and of course the blood pressure. Like even if you're going to put a 30 ml per kilogram per hour, IV bolus, like 2 liters, for example, technically 2 liters, the patient is not responding. Patient may have gone into what? To your multi-organ dysfunction syndrome. In other words, there's already an organ failure. Okay, an organ failure. Okay, let's take a look at the focus, on this sepsis and septic shock. This is very crucial here. In the middle of your sepsis and septic shock, there is what we call as your severe sepsis. This is where are we going to like really give a focus, because anytime the patient can deteriorate fast, okay, between sepsis and septic shock. It's very important for the nurse to check for lactic acid on this case, and as well as MAP. These are the two important things that you need to remember. The lactic acidosis and the MAP. If it's if it's less than 65, that's gonna be a different story, because again, this patient has to go to ICU. All right, the patient needs to have a fluid management. If your patient is having some form of congestive heart failure, you have to be conservative to that. You need to give pressors like your Levofed, right? Your norepinephrine, right? So anyway, so take a look at this one, sepsis and your septic shock. There's something in the middle, which is what we call as your severe sepsis. The two important parameters that you need to look at are your lactic acid. Get your lactate. It can be taken from an ABG. It's either arterial blood gas, from the arterial blood gas, arterial lactate, or the venous lactate. Okay, so lactic acidosis. It depends upon your hospital policy though, but it's usually 2 millimole per liter. If it's more than 2, and then okay, lactic acidosis. And plus the fact that your patient is experiencing what? SIRS and sepsis. Does that make sense, guys? All right. And then MAP, your mean arterial pressure. This is very important. If you are answering sepsis kind of questions, this is your background knowledge. Did you get me, guys? This is very important. Again, SIRS, sepsis, septic shock, and we don't want organ failure, kidney failure, for instance. Okay, if you check the renal panel, everything is messed up. Bone and creatinine is already elevated. Okay, so anyway, let's go back to our problem. Okay, so I guess the patient is already developing what? Drug your what? Septic shock. Let's go to your septic shock. That's the answer. Because if you take a look at, this is not sepsis anymore. All right, this is not sepsis anymore. Everything is there. Especially your blood pressure is less than, a 65. If you compute or calculate it, it's already less than 65. All right, so septic shock. Now let's take a look at the actions to take. Let's take a look at the actions to take. Are you still with me, guys? Okay. So let's see your actions to take. We only need 2 actions. I told you these are all important, actions to take. These are all correct. Again, prioritizing. What's the most priority here? Draw labs for serum lactate. Let's see if that's important. Administer vancomycin. Yes, it's very important. Obtaining blood cultures, pan cultures, yes. And NS bolus. The most important here, remember the patient is already developing shock. The most important is what? Can I get your answers, guys? The 2 most important actions today. We're almost done. The 2 most important actions to take. What are those? Okay, basing on the given choices. You only need 2, guys. As much as possible, there's a point system here, but you need to be perfect. Okay, you need to be perfect. You need to accumulate points. That's a good thing about NGN, because it's a point system these days. But you need to be perfect to accumulate your points. Vancomycin, between vancomycin and serum lactate, remember I told you, the most crucial is your lactic acidosis and your MAP. I'm going to suggest to the doctor, doctor, can I get a lactic acid baseline? All right. Again, severe sepsis. The most important parameter is the lactic acidosis. I'm gonna pick that one and then drug it. Okay. Administer vancomycin. Yes, it's important. Obtain cultures. First, you obtain cultures before you administer vancomycin. That's basic, right? Cultures first before you start your antibiotics, right? So as soon as possible, if the patient gets into the hospital, get the blood draws, the blood culture. I mean the cultures right away. Okay, especially your blood culture septicemia, right? And then that's the time you're going to administer antibiotics. Anyway, basing on this, comparing these four here, I'll go with your drawing labs for serum lactate and more importantly, your bolus. Remember, your patient, can you give bolus on this patient? Can you have at least an aggressive, fluid management? Yes. All right. The patient doesn't have any congestive heart failure, though the age is considerable because it's already 66 years old. But for me, I'm going to be more aggressive on my fluids, not the pressors, because there's a lot of disadvantage for your pressors as well. Bolus. I'm gonna give bolus to your patient. All right, 30 ml per kilogram per hour. Again, that's another background knowledge, guys. 30 ml per kilogram per hour. It's about 2 liters of bolus to your patient. It's a fluid, resuscitation. Well, the patient doesn't have a CHF, like I said, so it's okay. If the patient has CHF, that's the time you think about your what? You think about your pressors, your Libofed, for instance. So I'm gonna answer drawing labs for lactic acid and as well as your NS bolus. Those are the two most important. But take a look at vancomycin and obtain cultures. These are also important, guys, but the most important. That's why in the NCSBN clinical judgment model, what does it say? It says prioritizing. All right, prioritizing. That's your most priority here. But again, it's backed up by your sepsis continuum concept. So again, concept building in NCLEX is very, very important. Okay? So as much as possible, you have to dig in, dig in, dig in. So what is this really all about? All right. So let's go to your parameters to monitor, the most important parameters to be monitored. Okay. Blood glucose is also important because if you have diabetes, it can contribute to the disease condition, to the sepsis for sure, right? Because it's multi-system kind of disorder that messes up everything. It exacerbates everything, right? So you monitor the blood glucose, it's correct. Serum lactate, yeah, it was also mentioned, it was already mentioned, action to take. Serum lactate, yeah, definitely it's important to monitor every 6 hours. You can also do that like times three, only times three, because there's a lot of blood works as well. So 3 times checking your serum lactate is also depends upon your hospital policy. You can do it like after 6 hours, sometimes after 4 hours, right? To see the progress. CBC every 6 hours to check for the effectivity of your antibiotic, especially if the infection is progressing. Okay, so CBC is also okay. Vital signs every 5 minutes. I would say vital signs every 5 minutes because remember the patient is already developing septic shock. Okay, anytime soon you see your patient is already developing multi-organ dysfunction syndrome. In other words, there's already an organ failure. Check vital signs every 15 minutes. It can go down drastically and suddenly. So I'm gonna drag it. Okay? So CBC every 6 hours, serum lactate, blood glucose. Instead of the blood glucose, yeah, it's important again, but the most important among the three in this case is your serum lactate. Remember, those are the two crucial things. All right? So it's kind of challenging, right? Because these are all correct answers. These are all correct answers, but it's gonna be a challenge because you need to pick the most important and these are all effective, guys, right? The most important, the priority for your patient, right? So vital signs at the same time your serum lactate. It's already being said in your actions to take. So just follow it. Serum lactate. All right, so I guess then click the submit button and then you'll be okay. So the answer here, the potential problem, actually the existing problem, it says like potential problem because we're not doctors, right? So just to give a cushion to our profession, you know what I mean? Like just to give a cushion to our profession, it says potential problem. All right, so potential problem that the doctor is thinking about to support them is actually septic shock. And what are the two important aspects to, important actions to take? Draw labs for serum lactate because it's very crucial, between sepsis and septic shock. The patient is already developing shock, and your NS bolus. Okay, 30 ml per kilogram per hour. That's about 2 liter of NS bolus. You can also give LR though, but usually it's saline. All right, but be careful about hyperchloremic acidosis. That's another knowledge, guys. Anyway, and then parameters to monitor. These are all important, but please make sure that serum lactate and your vital signs, close monitoring every 5 minutes is being taken care of. Okay, so let's move on. I guess this is the zoom in version. So the answer is no, those are different. It was there's a technical error there. Anyway, these are your answers. The one that I checked. Okay? So I guess we're done. Like it's 7:01 here in the morning. Like I said, I'm here in Beaumont, Texas, and I'm happy to see you guys again after 2 months. And let's do it again next month. We're doing it, of course, with AMN together with IPAS every third Monday of the month. It's either me or Emil, or could be probably anyone from us in IPAS Online Review and Mentoring Academy. I would like to leave you this one. Uh, tenacity. All right, tenacity. Tenacity and enthusiasm are actually two the same. Those are two the same stuff. Like tenacity or enthusiasm. It's tenacity is a superpower for me, or also known as enthusiasm. Okay, how come it's a superpower? Like I have to really get it. Like you have to be really really excited and enthusiastic. I share this, every now and then to our students. Enthusiasm. The root word is enthusiasm. The root word for that is endo, means what? Within. And theo means what? God. So endo, within, and theo is God. Enthusiasm. God within. Or also known as tenacity. That's why it's a superpower for me. And you will be able to make it to your journey, to your NCLEX. Good morning, everyone, and happy holidays, Merry Christmas, and let's enjoy this celebration because this is only once in a year, right? So thank you guys for coming here, and see you next month. Bye bye. Hope you've learned something.